Now I will introduce Dr. Jonny from Indonesia. He is the head of nephrology division at Gatot Subroto Army Central Hospital, Jakarta, and deputy dean at Defense University of Indonesia. And he will address the pilot study of HA130 in MHD patients. Please, Dr. Jonny.
Thank you very much. Ladies and gentlemen, good afternoon. And first of all, I would like to say thank you to Jafron to invite me in this amazing meeting. So this afternoon, I will talk about the pilot study of HA130 in maintenance hemodialysis patients in Indonesia. My presentation divided into 4 parts. So for the introductions, as we know that hemodialysis patients are in higher risk of mortality, particularly cardiovascular death, compared to the general populations. It's related to malnutrition, insulin resistance, refractory hypertension, left ventricular hypertrophy, and chronic systemic inflammations. So hemodialysis has a limited mode that is limited to clearance of small uremic toxin only. So for the higher long-term uremic complications from middle to large molecular uremic toxin, it's related with this. And the retention of middle to large uremic toxins include B2M, leptin, IL-6, and PTH are strongly correlated to worsening of renal function and cardiovascular mortality. Also reduced quality of life. It's related with pruritus, sleep disturbance, and anorexia. So blood purification techniques have been developed to remove middle to large molecular weight toxin, including hemoperfusions, hemofiltrations, and hemodiafiltrations also. So combinations of SD with SP have been shown to be safe in reducing mortality and improve quality of life in the XD patients. So we can skip this slide, and this is the technique of the combinations of the hemodialysis with hemoperfusions. So our research methods, it is a quasi-experimental study with pre and post-test design in 40 end-stage kidney disease patients on routine twice-a-week hemodialysis, 5 hours per sessions. Location in 3 hospitals in Indonesia. So the study durations about 8 weeks. So this is the sample size. It's about 15 for each group, divided in 3 groups. So this is the dependent variables that we measure, objectively by B2M, leptin, PTH, IL-6, and subjectively by appetite score and pruritus score and sleep quality. This is the inclusion and exclusion criteria. Sorry. The inclusion criteria is age 18 to 75 years old, on routine hemodialysis more than 2 years with anorexia, pruritus, and sleep disturbance, and received standard hemodialyzations with blood flow more than 200 milliliter per minute and dialysate flow more than 500. And vascular access using epifistular or epishunt. Exclusion criteria: if the patient unstable with the thrombocytopenia less than 50,000, leukopenia less than 4,000, leukocytosis more than 11,000, patients with malignancy or autoimmune, pruritus and sleep disturbance due to other causes, systemic infections or sepsis. This is the dropout criteria. So the patients, 45 HD patients who fulfills inclusion and exclusion criteria, but 5 dropouts, so total subjects is 40, and divided to 3 groups: HD only, and XD with XP once in 2 weeks, and XD with XP and in once a week. So the outcome, we measure objectively the level of B2M, leptin, and parathyroid hormone, and interleukin-6, and subjectively with quality of life presented with hunger and satiety visual analog score, scales, pruritus intensity, 5DH scale, and sleep quality with Pittsburgh sleep quality index. Treatment regimen: in 3 hospitals, the dialysis machine use Bibron, Nipro, Fresenius, and Wesley. Treatment was based on 2 times weekly dialysis section, 5 hours per sessions with blood flow more than 200 and dialysate flow more than 500. This is the statistical analysis, I think. And how about the results? Baseline characteristics. In this slide, we can see that no significant difference between 3 groups in sex, age, body weight, systolic blood pressure, heart rate, comorbidity, anxiety score, also in depression score. How about the laboratory changes pre and post treatment? Also no significant between 3 groups. And if we see the efficacy on removal of large uremic toxin, in this slide we show that B2M, leptin, and PTH, also EL6, also no significant difference between 3 groups, but maybe it's related with the durations of the study. It's about 8 weeks, so maybe we have to make the study longer. But if we see in this slide, subjectively, there are significantly increase or improvement in the hunger, anxiety, pruritus score, and sleep quality between the 3 groups. So in the group with the XP, there are significantly improved the hunger and satiety score, sleep quality index, and pruritus score compared with the XD only. So in my conclusions, combining XP to XD improved clearance of middle to large uremic toxin, although no significant change were shown when compared to XD only. Subjectively, all three groups show improvement in satiety, pruritus, and sleep quality. Additional hemoperfusion to routine hemodialysis significantly resulted in overall quality of life, especially better in sleep quality. So our recommendation, the promising result from this study warrant further investigation and research on a large scale and longer time, including clinical trials and long-term follow-ups in Indonesia to determine the feasibility and efficacy of incorporating HP into routine HD treatment. I think that's my talk. Thank you very much for your attention.
Thank you very much for this very interesting presentation. So